Dr. James, I hope you're going to stick with us.
Is there any questions?
Yeah. Okay. So the moderators have sort of taken the first crack at it, so I'm going to keep with that plan. Dr. James, you mentioned multiple times in your presentation that you take a trauma-informed approach to this work that you do. Can you tell us a little more about what that means? And one specific thing I'm curious about is, do you do any formal screening for PTSD and or treatment directed specifically at trauma-related symptoms?
Okay, so the community violence response team I was telling you about, the trauma service team, they are the ones who do screening for PTSD. The other thing about that is they go beyond the bedside. I mean, they see the patients in the hospital every day while they're here. And even if they don't get admitted, they will provide services not only to them, but to their family members, and they provide services wherever they want it, at their house, you know, at a library or McDonald's, wherever they would like, you know, to be seen. But they are, the trauma service is the service that does the screening for PTSD. And you asked me something about, more about the trauma-informed approch.
Yes.
And what we basically do is, with staff at least, we've had some simulations. Our staff has done simulations in the simulation lab here for nurses so that they understand the behavior is a manifestation of the injury. I mean, you know, these are like neurobiological sort of things that happen inside our bodies. I mean, it's horrible to have to reflect on this, but when the Boston Marathon happened, there were patients here who nurses reported, you know, had outbursts at various different times, but no one saw that as a negative behavior. People sort of understood that, you know, they had been traumatized they had been assaulted by someone, and you know, they had these injuries, many of them life-changing, and so they were allowed to respond in that way. And we sort of we had a Schwartz round here, and we used it as an example of to teach about trauma. You know, that trauma affects, you know, we're all human, and you know, we have the same sort of biological, neurobiological systems, and hence we can be affected by trauma in very similar ways. So, as unfortunate as the Boston Marathon was, and indeed it was a tragic time here, but it was a teaching moment. It was an opportunity for a teaching moment.
Thank you. Do you have a question?
It's partly to you, but unfortunately the two people who I thought might also respond just left the room. But I'm wondering I'm sorry, I'm Pamela Russo from the Robert Wood Johnson Foundation. I'm a member of the Roundtable. When in the community, the neighborhood that you said had the opposite result than what you expected.
The bad outcome?
Yeah.
Yes.
Did you ask the outreach workers what they thought was going on?
I did. Yeah, I'm glad you asked that question, actually. When I had my first round of, you know, data from the first round, and I saw the uneven pattern of results, and I shared it. I didn't share it with all outreach workers, so I went to a couple who I trusted the most, and I said, explain this. And, you know, perhaps, you know, take this for what it's worth, because it's their experience and their lens that they're looking at it. But they said, well, that's the easy question, you know. The workers in that area were just there for a paycheck. The workers where you saw enormous reductions in violence, it was their life mission. And he talked about a different level of commitment of what it meant to do that work that wasn't there in the places that weren't getting the good outcomes. Now, I believe that. I believe that this is something we discussed a little bit over lunch, that this is a program model that's highly dependent upon these credible messengers building trust and doing a type of work that, yes, they all get the same sort of training that I'm sure is helpful. But I think people bring different things to this job, and some are gifted and passionate and able to look. This is incredibly hard work. I should have. It sort of came through in our earlier discussion, but when I give this talk generally about this program, I say, okay, think about this. This is your job now. Your job is to go in one of the most dangerous cities in America, and where you're going to find the most dangerous neighborhood, and you're going to find the most individuals there at greatest risk for being shot or shooting, and you're going to work in the middle of the night. You're not going to get a gun, a protective gear, or anything. We'll give you some training and your own credibility. And we're asking a lot, and honestly, we're giving little in terms of salary. And what I think we're learning in Baltimore, I think what we're learning in Baltimore is we have underinvested in the workers. This program succeeds or fails based upon the workers, the degree to which we get the right ones, that we support them in the right ways. And while I'm proud of many of the things that has been accomplished in Safe Streets, the thing that I am least proud of is when the program started in 2007, their wage for doing that dangerous work that I just described did not change until, I think, last year. And to me, that just, it spoke volumes. And I think what Devon was teaching us, I believe, what he taught me anyway, is just how incredibly important it is to treat people with respect, to support them in ways that they can succeed. He was talking about it more in the context of the direct people you're trying to influence with the program, but I think that applies equally as well to the workers with this program model.
I'd just like to add that I think the real value of this whole model, cure violence or whatever you want to call it, is the fact that you can have people from that neighborhood with the background and the experience to be called credible messengers that have the ability to tap into the information that's available in the community about beefs and conflicts that are about to erupt. But that means that, just as Daniel said, you're hiring people with challenges of their own. And so when I think about the trauma-informed approach, it should be the trauma-informed approach to hiring, supervision, management, and support of those workers as much as the participants. And we, for the Robert Wood Johnson evaluation, we are trying to at least get some image of the different program models and their emphases. But just because a set of programs share the same brand name doesn't mean they're all doing the same thing, and that's a real challenge. There are variations between sites that happen because of the personalities of the people running this program or the number of people hired and their background. And there's an epidemic of confirmation bias among these programs because we all see things. I have my own biases about what makes these programs strong. But we do have to invest in enough research and fidelity measures to know which exact components and behaviors of the programs themselves lead to the best outcomes. And we are far from understanding the huge assortment of variables that go into that mix.
Yeah, I just want to say one more thing on this topic of the more general question of the uneven outcomes. I put it principally in the frame on the workers and who they are and what supports and so on and so on. This whole event is about community, right? There are important differences in the communities where it's been successful and not. The two areas where it's been least successful, without a doubt, are the most challenged. in a number of respects in terms of community organization and participation, abandoned buildings. They parachuted these workers into a place with little else there. And they're great people, they're not miracle workers, okay? So the places that had good outcomes, the program and the workers had something to connect to more so than they did, I think, in the places that did not have good success. Yes?
Yes, hi. Can you hear me? My name is Antonia Clemente. I am with the Healing Center, and we are a domestic violence, gender justice organization. And what brought me to this conference today was the topic around community violence. But what I'm also feeling a sense of what's not part of the conversation as we're talking about violence in our society is violence against women and children in our society. Every day, 3 women are murdered in this country. 1 in 4 women will be a victim of domestic violence, 1 in 7 men. 3.3 to 10 million children witness violence in their home every day. Teen dating violence is on the uprise, where 1 in 3 teens will experience some form of violence. So the question that I have is, why isn't it part of the conversation? That's number 1. Number 2 is I'm hearing about the CURE program. I am wondering, is there any work being done as we talk about gun violence and how that intersects with domestic violence? How many women are killed on a daily basis or killed in this society by guns? So we need to make the connections between gun violence and violence against women. So I'm just wondering what studies being done, if that conversation is part of this roundtable, and if it's not, I urgently say that it needs to be.
Thank you for sharing both the facts and your perspective. I think that's very valuable. Here's my response, at least as it relates to the Cure Violence model. I think the Cure Violence model was created more to address gang violence than anything else. That being said, they clearly recognize that the population of interest, that they're trying to change social norms as it relates to violence, the partner violence is a component of that, and they are directed to try to address that as well. It is not front and center as it is to your work, very important. And I do think that you're absolutely right that we compartmentalize more than we should gun violence. The individuals at risk in some of the mechanisms are relevant across the board, where we're talking about intimate partner violence or community violence. And it is not adequately centered, a piece of our current program on that. So I'll simply acknowledge that, but I do think that many of the concepts that we're talking about here, with the importance of the underlying social determinants of violence, of inequality, of racism, the role of guns, all of those are incredibly important, as you well know, as it relates to women's safety and intimate partner violence. So I think, again, I hope that you and others can appreciate that what we're talking about today has relevance on that topic as well.
No, and I do. I appreciate that, but everything intersects with one another.
I'm sorry, say again?
Everything intersects with one another.
You're absolutely right. I couldn't agree more. And I think we over compartmentalize, and some of these root issues are the same. They're absolutely the same. Yeah. Dr.
Hi.
Brannis.
Hey, Charlie Brannis from the University of Pennsylvania. I really enjoyed your talk, and I was very interested to see some of the early findings on this. I especially like the variety of metrics that you both used and brought into it, and the nuance that you did in terms of the different neighborhoods. I guess my question is more so, it seems like this is already rolled out in many, many cities around the country. Now that Cure Violence is, I think it's like the number 9 NGO. Someone had shown that in the world or something along those lines that had been voted. So it's rolled out in a lot of places. And so how in the future do you think we're going to get promising violence prevention programs like this to get paired with perhaps a university or a scientific evaluation team early on to begin thinking about starting some sort of a match and being more symbiotic about what both of these groups can do with each other?
Jeffrey, I'll let you take a crack.
That is what the Robert Wood Johnson Foundation did by attaching us early and actually starting 2 new programs. So our contract includes money to pass through to the program operation so we could do baseline pre-operational measures, which was very good. And Cure Violence is not just nationwide. They have sites around the world now in different countries. I don't know. I've never been in the position of trying to orchestrate something that complicated in terms of the funding structure. But I think at least that foundation has expressed interest in knitting together the evaluation partners and the programmatic partners to have a common conversation, which I think is very important and maybe will happen in the future.
So, yeah, the 2 entities funding a lot of the research has been Robert Wood Johnson and CDC, and there's been others as well, I guess. You have other sources. But the CDC has a program to support centers working on youth violence. And our center at Johns Hopkins, this program was not the only thing, but central to some of our work, but the same for the University of Chicago as well. So we're trying to learn from each other as we go. And I do think that we know a heck of a lot more than we did when, we started.
And the hospital component is incredibly powerful if it's done well. The risk is the political and economic power of the health sector can easily overwhelm the neighborhood base of what a Cure Violence program is supposed to be. And you don't want to professionalize it too much. So somehow there has to be a linking mechanism that allows the neighborhood-oriented credible messengers to feel comfortable interacting with the health industry. And the best example I've seen, I haven't seen too many of them, but we were visiting New Orleans, and that city has a pretty effective collaboration between law enforcement, the hospital component, and the neighborhood-based component, where they all seem to respect one another and work well together. And the most important thing is that the police understand that they should not interfere with or dilute the power of the neighborhood component. And that means they coordinate and communicate at the upper reaches of that department. Whereas I've heard other horrible stories about police departments that try to undermine the program by actually walking up to workers on site after a shooting, and then the whole neighborhood sees it and thinks, oh, I'm not talking to those guys anymore. So they have to have mutual respect. I think some cities have pulled it off.
That's an excellent point, Jeffrey. I'm really glad that that was said before we ended our conversation on this. I want this, I'd like for you to...
I just wanted to make a quick comment for the person who brought up the question about domestic violence.
Okay.
I'm Betty Lee Davis, and I'm a clinical social worker. I've attended a number of these workshops now, starting with Sandy Hook, mostly the global violence ones, but I just wanted to mention in the last fall there was one focused on intimate violence, and Jacqueline Campbell is someone that she might want to be in touch with. That's her particular focus. She's in Hopkins in nursing, and she usually brings up that, but she's not here today, and maybe the focus wasn't.
So you're absolutely right. There have been separate workshops.
So it is addressed
focused
in different,
on this, but I think it is worth noting that when we think about community and community violence, we can't just think about this with respect to youth and gangs and so on. There are other tentacles to this that are all related. And again, I'm glad that you shared your...
Right, and I think Jackie Campbell's brought that in other broader contexts, just as this person has, and maybe someone for her to connect with.
Okay. I think we just we're running out of time, but I want you to have a chance. Well, thanks. If someone gives me permission to run over, I'm okay, but okay, I got it. We're rolling.
It's Tom that has the control here.
I'm going to look to Tom. He's our chair. But
so one last point, one last question. You mentioned, and I think particular the issue of scale and reliability of execution and leadership, and the problem of variation in some of these models as they've been applied in different areas of Baltimore and in other situations. And it raises for me, given the fact that I come from a health system where we have both operations and then research in separate groups with subcultures that are very different. And I'm not sure I could speak for a subculture of a city government, but I really wonder if there aren't things to be learned from the business school in terms of leadership, reliability of execution, and scale. This workshop has had, this series of workshops has had a previous workshop some years ago now on scaling and implementation of that. And I just wonder if those topics need different disciplines to come and collaborate across in terms of sharing what they already know about creating consistent leadership and scaling interventions so that they're more clearly reproducible across broad geographies and across organizations. So I just wanted to mention that.
Okay, point well taken. I'll just mention very briefly that just this year we formed an advisory board for Safe Streets Baltimore that I co-chair, and we've brought to the table precisely people with those kind of skills to help us think about so many of our programs, Safe Streets just being one, the way we think about them and do them and evaluate them is, oh, here's a model. We've got an enormous city with an enormous violence problem. We'll take a little slice here and we'll see what happens in a little slice here. And we learn a little bit from that, but in the end, have we changed Baltimore's problem? Have we changed gun violence in America from this, we're going to take a little piece here and there? And you're absolutely right. And what this should be what our eyes are on is the population effect, right? That's why we're all here, and we haven't really carefully thought that through, and I hope somebody will do it other than me, because I don't have those skills. I can think about those things, but we need that kind of expertise to really take us to the next level, even though I'm in health policy and management. I don't know a thing about management.
Hi, I am looking forward to being on the planning committee for an upcoming roundtable that is going to look at privilege as one of the root causes of violence in poor neighborhoods. Until we get there, I'm going to preface this by saying that, Daniel, this is not a personal attack to you. This is an important question about how we structure our staffing in these type of programs. And I'm going to ground this in an example of a battle that I myself had when I was a youth violence prevention researcher at an Ivy League institution that shall be renamed nameless. Because I had to fight so hard to get 2 of my community outreach workers to be paid at the graduate level. They did not have an associate's degree. They were working on their associate's degree, but I wasn't buying their academic expertise. I was buying their street smarts. I was buying their relationships in the neighborhood. So I understand, and I'm so glad you brought up the comment that the staffing was going into really harsh conditions, and I am angry that they were paid so little and that didn't change over a period of almost 10 years.
Right.
So can you speak to that?
Oh, yeah, I'd be happy to. And clarify, I'm just as angry as you are. I don't pay them. Okay, I'm an evaluator of the program. Can I comment on it? This is how the city structured it. I don't think it was structured well. I think that in a place that with big problems and little resources, everybody's tried to squeeze as much as they can out of everybody, from top to bottom. And it's not, I spoke about this wage issue for years, and it didn't change. I don't know exactly, but I think they're finally listening, is maybe the more hopeful piece of this. I think they've understood that you get what you pay for, and if you don't invest in people and respect people, you're not going to get the outcomes, and you're not, frankly, going to get the credibility that you actually believe in what this program is about. So I think this is incredibly important. I'm glad you raised it.
And not just salary, but interruptions. A number of cities pay these workers through nonprofits, and city contracts often have gaps. And it just makes me enraged when city officials say, well, it's only a couple months. And do you realize what people live on, and to interrupt, to have no pay for a couple months, and the ones who leave the program are the ones most capable of getting another job, which means you're constantly losing your best workers. And it drives me nuts.
That has happened in Baltimore as well.
And New York and Chicago.
And it is a chronic thing, and I think, again, it speaks to this issue that we really need to figure out how to do this right. I think we have a kernel of a general good idea that can save lives, but we're nowhere near to really fully realizing that without, thinking this through so that we don't have those kind of gaps. We don't have 8 or whatever years before somebody gets a raise when they're doing that kind of work. Tom, can we take another? I'm looking to you, bud. All right.
So I just want to piggyback on that a little bit, because I wanted to ask about sustainability and social justice. In that, what we often hear about some of these programs, I know there's not consistency across, is that the workers work, and I think Thea said this, 24/7, 365, right? There's an expectation that, and with that comes a question about sort of, it's often, and I know this happens, sort of folks in communities are dedicated, they're incredibly dedicated to this, and yet 24/7, 365 doesn't really sound like a job. It sounds like servitude, and it sort of reimagines a different state. So I wonder, from a sustainability perspective, even when you see effects, if that is the staffing model, what is the likelihood, because I hear turnover, or what are the remedies to being able to fully implement it in a way that's going to be effective?
Dr. James, are you with us still? Are you there? No? Well, the 24/7, I think, was referenced by Dr. James, but I will tell you that the Safe Streets workers, at least some of them, again, the ones that I was saying, it's their life mission, that's good and bad. I mean, it's good in that they are incredibly good at what they do, but I know, I have friends who are workers, and I see the toll it has taken on their mental health and every aspect of them. It's wrung them dry. And again, we need to think about a sustainable model that this is a human resource issue, and we need to find ways. We can't work people at that level. One thing you have to, if it's not obvious, is that many of them are doing precisely what we want, which is they're the role models, right? And people see all kinds of problems around them in their communities. And isn't it great that they're looking to these outreach workers who are promoting peace as the problem solvers? But those problems are so deep and constant, and they typically live in the community. They don't drive to the suburbs and call it a day and sit back and, have a cold one. People know where they are. They have their phone. They'll knock on their door, okay? So this is the reality of this work, and we have to recognize just how challenging it is to do and support the workers. They're saving lives, and we need to value them.
Question?
Yes, go for it.
Okay, my name is Debbie Indike. I'm retired from Mount Sinai Preventive Medicine, where I spent close to 30 years working with AIDS and substance use and addiction and all the other problems. And I would just like to reiterate the issues that were raised by people who started to talk about the overlapping but not discussed issues today that we all have learned from and must continue to learn from. And it seems to me very disappointing and distressing to see how many of the lessons that we learned about integrating prevention and treatment with HIV took 30 years to do. I was doing it 20 years ago, working both in the community and in an academic center, and knowing that we always have to think about anticipatory prevention, learning from what we found out yesterday and incorporating it into the lessons that we've all learned. And no matter which conference I go to in my new state of luxury of retirement, I find the same problem, that we're creating new silos. CDC has expanded dramatically. It's still silo-based in terms of even how it's defining prevention. Yep. We have to define prevention holistically across the life cycle and looking at risk and better ways to develop the cascade model, to understand the cascade model that's just becoming understood in AIDS about why we lose people at different points along our interventions. We're still doing acute level interventions in this talk today, and I think we not have to speak group coming together, dealing with people, parents with little kids, people who are old, learning from and building on, not separating out these knowledge bases.
Amen. Thank you. I got this motion from Tom. This has been a great discussion. Thank you for your participation. Oh, sorry. We got one more? Okay. Please.
Wow, okay. Thank you. Manna Stiliano. I'm here from Safe Horizon here in New York City. And my question is, one of the things I think, speaking for me, that I'm so appreciative about this model is that it's really grounded in the community, trying to utilize strengths from the community. And yet we know that these communities are not silos and that they're so heavily impacted by larger structural abuses between poverty and racism, affordable living, livable wages. And so as we start to evaluate this particular model across different neighborhoods and different cities, have we been able to start looking at the ways differences in communities around those structural issues impacts the ability of this intervention to be successful?
I think I'll take a quick crack and then hand it over to Jeffrey. So I don't think that we've done what we need to do fully on that. I think we've sort of given some general observations around that. And, it should be no surprise that if you're going to the places where the problem of gun violence is the worst, these organizations will be most stressed, least resources, and so on and so on. And that is another part of the patchwork of some effective, some less effective. It's how overtaxed these organizations are. And honestly, how truly committed they are to the community. In Baltimore, anyway, it's a real interesting mix of sort of who, in essence, signed up to do this, in a degree to which you could really imagine that they are truly a community, grassroots, as opposed to something else. So it's, I can say that we've had the highest resource organization not do well, okay? So it's not just a resource piece. It is a commitment piece as well as resource. That's my last, if I have any pearls of wisdom, that's it.
And I'll just say some of the knowledge development in this area is restricted or inhibited impeded by the issue of data and outcomes. I was in a meeting once and a physician said, I can't believe this field is so underdeveloped. I can tell you exactly how many hepatitis B cases there were last year versus this year. And I said, that's because you don't have a state legislator deciding what hepatitis B is. And every state is different, and there's a threshold for who's an aggravated assault and who's not. And then there's the social dynamic, and this maybe has an analogy in medicine, the social dynamic to where cases are perceived. I used to be, a long time ago, I was a child welfare worker, and I remember how many horrible cases of child abuse I was aware of in that agency that occurred behind wealthy doors and were never reported and brought into the system. So if you are violent in a neighborhood where the police are everywhere, you will be detected and brought in and processed. Violence in another neighborhood, as we just saw with the Stanford case, is handled very differently. So it's part of the learning in this is a problem of consistency of outcomes. We don't have, like an HIV test, you know who has HIV and who doesn't. It's very hard to know who's been violent or who will be violent, and that squishiness makes it really hard to implement solid programs and evaluate them.
I would suggest, I'm sorry to just define that it's not that simple. We might know the test result today, we don't know about yesterday's behavior.
Or tomorrow, yeah.
Okay, I think we're done here. Thank you again for your participation.